So we are public.
But we start at 12. Now.
It start now.
We are allowing people in, so we will start in a few minutes. Looking forward to our good discussions.
So welcome everybody. We are still waiting for people to join and maybe to, I know, bring some food for those who are not with us, as this is a lunchtime webinar, and I hope you will enjoy it. We have almost 300 around. We have like 300 registered participants. So yeah, let's wait for them to join. And the webinar is being live streamed on Facebook, and it will be also recorded. We have some presentations from our distinguished guests, and those presentations will be also either sent to you or published on ETUI website.
Oh no, we are, I think, fully public, and welcome to this webinar. When we received the proposal from EPSU to do something around the transfer issue that was published recently about transforming care work, we thought it was a fantastic idea. Then we select 2 articles and organize this webinar, which is, I think, a mix of a very good academic article, and then to have the discussion from practitioners, trade unionists that know also the situation from the ground. And that's why we decided to organize that. And it's a long-standing cooperation with EPSU. And that's really a good way, I think, to cooperate and to put in the public debate academic article, but also the real life and the direction from the trading. So thank you, Jan Willem and Adam, for this idea, and without taking more time, because it's really a short webinar, a lot of good speaker. I give the floor to Jan Willem.
Yes, thank you very much, Philippe. Welcome. Good afternoon to everybody taking time to be with us here. So when ETUI had this item from transfer on transforming the world of care work, we thought it's a good idea to make that research more public, and also to draw attention to the experience of many of our affiliates, which are also mentioned in several of the articles which are in the transfer publication. As you all know, our members, and especially in health and care services, have been at the forefront of the pandemic. Many of our members have been infected in that work, and sadly, we count around 4,000 workers in health and care services which have died since the start of the pandemic. One of the things the pandemic has done, and some of the articles draw attention to that, is that the pandemic has made clearer the already existing problems of lack of staffing, and hence the need for appropriate staffing levels, problems of low pay and poor conditions in some areas, the problem of a lot of work stress and workloads, and what we see in Europe. And one of the articles, I think, from Kurt draws attention to that, is also the mobilization which is going on of health and care workers to get better collective agreements. Just yesterday in the Netherlands, there was the strike of the FNV comrades in the academic hospitals, as the government and the employers are not giving them an appropriate pay increase. There's also long-standing strikes, for example, in Charité in Berlin. So we were very happy with the transfer article, the marrying of academic research and practical experience of the trade unions. Many of the articles also draw attention to the need for strong collective bargaining in the sector, strong social dialogue. We're also happy that we will start a process of social dialogue with the European Social Service employers. We're involved in European Works Councils in a number of elderly care companies, like Orpea, a French company. Not always the best reputation, some of these companies. In Orpea, one of our German members is being pursued in court for her trade union activities, and we're of course in full solidarity with them. As Philip said, there's quite a lot in the articles that we want to discuss, make public with you, and to keep it short, I wish us a good discussion, good debate, and we look forward to continue working with your researchers, with our affiliates, to improve paying conditions in this important sector in Europe. We all know there's also a new European context with Ursula von der Leyen's European care strategy, the long-term care report, the European Pillar of Social Rights, which adds to the way in which the European Union also becomes more important for the whole sector in terms of its regulatory framework, but that we will hear from one of the speakers later on. So without much further ado, I'll give it back to Adam.
Yes, thank you, Jan Willem, EPSU General Secretary. I think now we went to the stage that we would like to very much listen to the presentation from our distinguished academics. So I would like to give the floor to Valeria Polignano and Matthew Johnson for the introductions to this special transfer issue. Valeria, the floor, and Matthew is, or the screen in this case, is yours.
Yeah, thank you very much, and it's really a great pleasure for us to be here. I will just share the screen with our very short presentation with myself and Matt, so I don't know whether you can see it.
Yeah, we can see it very much. If you could just put it in the presentation mode, like, you know, to make it. Yeah,
exactly. Let me see whether
I can. Perfect, excellent.
It's okay, yeah?
Yes,
can it
excellent.
Be like this, yeah? Okay. Yeah, okay, that's good. So, yes, well, let me say that, yeah, as I said, it's a great pleasure to be here and, you know, to see now the possibility for us to see the special issue being on the table. And we are really delighted to hear that the work as we do as academics really is also kind of appreciated by the stakeholders. That sometimes, you know, there is always a kind of discussion among academics to think about, okay, are we doing really what needs to be done? So we are really, I think, delighted to hear what the General Secretary of the EPSU just said. So we have very, very short time. So let me go into the starting of this. We will share, as I said, with Matt. So this is a special issue. It was a journey. It was a very nice journey we did with Matt. I still remember when we were discussing, this was just before the pandemic started, we were discussing about something about care. We wanted to do something about care. We were very well aware about the kind of impact on quality of jobs, kind of disruptive impact in this sector, and we wanted to do something about it. And we started to be more and more convinced about the necessity to do that when, in fact, COVID hit. As has been indicated by the General Secretary, by Jan Willem, in fact, COVID crystallized some kind of structural disruptions already, problems, which were in fact already into the kind of sector. So in fact, we saw that COVID was challenging a lot. The pandemic was particularly for us a kind of opportunity we saw with Matt to reflect on the kind of resilience of care system across Europe. And we wanted to go for this special issue. And we thanks very much Transfer for being, you know, being so generous to answer to our contributors, to giving us the possibility to publish this special issue. And, you know, I want to thank Philippe Pochet there and representing, in fact, as also editor of Transfer, giving us these great opportunities. Now, I don't want to go much more. A lot has been said already. I mean, we know that well, care has always been, the care sector has always been at the core of the attention since the last years. We know before COVID, people reporting in newspapers and media reporting about the staff shortages, but also the lack of personal protective equipment, but also the limited entitlement of workers, care workers, to welfare benefits. And these were already some symptoms of the crisis. Then, in fact, when COVID hit, we saw these, you know, becoming even more problematic. So what we wanted to do in this special issue was, in fact, to explore how policy, institutional, and market-driven transformations of these care regimes across Europe that have been impacted upon the quality of the care services and the quality of care work. This was very much at the core of our intention, and we wanted to do it in a kind of, you know, across comparative way. So we wanted...
My name, Marie Butler.
We wanted to basically look at these changing models of care delivery and care work in different countries. We selected some of those. For us, they were, you know, kind of reflecting, despite we can, you know, criticize it, whether we like it or not, the different kind of regimes of capitalism in different European countries. So we had some representation from more liberal economies, Ireland, but also UK, also Southern European experiences with Italy and Spain, Central Eastern European with Poland, and Nordic countries who have been kind of leading in terms of advancing for care as part of their own welfare system as Sweden. And of course, as has been indicated before, we wanted to have also kind of transnational vision, and we will, you know, basically listen today one of these presentations. I will give now the floor to Matt.
Yeah, thanks, Valeria, and thanks to the ETUI and EPSU for putting the webinar on and for helping us coordinate the special issue. I should kind of give my thanks as well to Valeria. This was kind of very much her original idea, and I came in to the process partway in development. So Valeria did a lot of the groundwork in terms of workshops and conference special sessions, pulling together the thematic content of the special issue and getting people on board. So definitely kind of thanks to her. I guess my reflections on working on the special issue and kind of making a contribution was that the timing was quite fortuitous, really. I mean, not that the pandemic in any way is something that we would have wanted to happen, but it did coincide with some of these discussions we were having about these kind of long-run structural problems in the care sector. So it was a way in which we could kind of draw attention to that and get some exposure. I mean, these are all things that everybody will be aware of, but putting them on the kind of political agenda was quite important. I think also in terms of the links between the macro and the micro level, that was something that I think came across really strongly in all of the contributions. So some of the issues that were being reported, the kind of the lived experience of care workers, the kind of everyday struggles for workwear, for health and safety protections, for decent minimum rates of pay, for rest periods, what sound like fairly minor issues were massively important to care workers. And there were a very clear reflection of kind of higher level policy decisions that were being made. So these big structural issues and problems in the care sector were being kind of illustrated and kind of articulated very much at the micro level. So those links were really interesting. I think also what it has done as well is really throw a spotlight on the multiple roles of the state. So this isn't necessarily just about welfare regimes in a broad sense, but the particular political choices of the state, how it structures care markets, the way in which it funds the way in which decisions are decentralized. State as is really important to understanding the kind of complexity of the care market, the way in which it interacts with private providers, the standards that it sets, the way in which it negotiates with a very kind of complex and fragmented market is really, really important. And I think that the final point to reflect on as well is that it would have been very easy to tell a very depressing, slightly gruesome story about the care sector, and that certainly is part of the story. But I think what we also wanted to do is to try and, I suppose, give some optimism that workers, that campaigners, that trade unionists, that policymakers can have an impact. This isn't a lost cause. This is something that we can and have to do something about. And hopefully that's something that comes across in each of the papers, is the way in which different actors are responding to some of these structural issues, and the ways in which they're making progress in various guises. So I'll pass back to Valeria.
Yeah, thank you very much, Matt. Well, I also would like to thank you for, really, it was fantastic to work with you. I have to say that. So, well, Matt highlighted a little bit, a kind of variety of different contributions that we had, the main thematics or themes which came across this different collection of papers, with 7 papers from, as said, different perspective, different countries, macro. What I would like perhaps to say is, as I said before, COVID certainly put a kind of attention on the importance of care as a public good, I would say, but also, in fact, as in shedding light on the problematics, it also crystallized, as I said before, long-term structural problems which were already present in the care services, how they were funded, how they were designed, and they are still designed, and how they were and they are delivered. And this is something which really has to change. We saw this being a big problem, and we saw this delivering a lot of problems, particularly during the phase of the pandemic. So what we could say, certainly what came across this special issue, is that variety is there, but there are also a lot of commonalities across these different stories and narratives across different countries in the care sector we have been clustering together. First of all, we see a lot of commonalities in the challenges that the care sector is affecting and is, experiencing, which in fact reflect a lot about the problematic of the coverage and the quality of state-funded care services. We also see here a lot of problematics, as also has been indicated by Matt, in terms of the stability of care services and the regulation of working conditions. So working conditions, job quality remains a critical issue in care. Now, the point here is that particularly, and that was also very much highlighted in a different contribution as a commonality, we see that the weakening of collective bargaining, in fact, and the role there of the unions. So the role of the unions in shaping job quality is very important. And the weakening of the structure of industrial relations and the challenges that unions have been facing, particularly in the sector, have been also, kind of affecting this kind of weakening and raising the problematic of working conditions in the care sector. We also see in the across the different contribution coming a lot of issue highlighting the various contradictions between the different roles of the state in shaping the market for care services, as in fact a policymaker and macroeconomic regulator, and also as an employer and a client at the head of increasing long and complex supply chain. So the special issue, as I said, highlighted a lot about a series of thematics and issues dealing directly or indirectly with this kind of contradiction. Now, very briefly again, today we will, hear we have 2 eminent speakers with 2 important contributions. The first one from Stan and Erne, and the second, in fact, from our Irish team, Murphy and O'Sullivan. Now, we want to say that, these 2 contributions are certainly linked one another. In the sense, as Matt already exposed. So in our special issue, we try to explore the consequences of this long-term fragmentation and marketisation of care for both quality and working conditions, ranging from a transnational level to the workplace level. So these are, you know, these two different papers, they match very well into another. In the sense that, for example, and I don't want to really jeopardize here the floor for Roland and Sabina, but certainly what we have learned a lot from from their contribution is that, in fact, if we want to understand the changing care regime within the European countries, we cannot deny the importance of this transnational arena and how, in fact, these links into market integration issue at the European level. We also
Valeria, sorry to actually step in, but my role is actually to make sure that we have enough time.
Oh yes, you're right. Well, I will then stop here. Yeah, I will then stop here and give the floor. Yeah, to the two contributors, and yeah, and then perhaps if there might be a room afterwards, dig also in other papers. Thank you.
Yes,
bye.
I think because we have a lot of people here, so we're very looking forward to question and answers after all of the presentations. Colleagues, I would like to welcome Mary Butler from the SIP2, from Irish Service Trade Unions, who will be also commenting to the articles after that. So I would like to now give the floor to Sabina Stan and Roland Erne, as you said, who actually wrote the first article in Transfer. It's about the new paradigm in health and care. And my introduction will be very short here, because this article is of particular importance for EPSU, because this looks not only on the care sector, but on the health sector. So this inclusion or integration between health and care sector, I think, are crucial. And when we look again on the recent EU policy in terms of the EU for Health program with increased budget of 5 billion euros that EPSU was protesting against, reducing this budget. But also when we look at the recovery and resilience facility, we always in EPSU say that it must be important to not only urgently support health workers in the health sector and the hospital sector, but actually link it with the social care and long-term care. And recently, we also observed this with the very famous report presented by the WHO or Regional Europe by Professor Monti on the lessons learned from the pandemic. One of the lessons learned was actually to link better health and social care sector and support the social care workers, as we are doing here in EPSU. Sabine and Roland, the floor is yours, and I will step in when you speak too long. And colleagues, you will receive this presentation, so no worries about that. Sabine.
Great. Thank you, Adam, and thanks everybody for the invitation to take part in this webinar. So basically what we argued in our article was for a change of the lenses through which we see healthcare and care in Europe. As we argue, in the EU, healthcare system are not so national anymore, given that they are linked across border transnationally in a larger whole, a system. Yeah, and in order to argue that, we looked at three interrelated processes which affect these transnational linkages: healthcare privatization, especially since the 90s, healthcare worker and patient intra-European mobility, especially since the 2000s, and EU laws and the EU's new economic governance in the previous decade. So in the 90s and 2000s, we have the European Monetary Union and Central and Eastern European accession, placing important fiscal constraints on state budgets, which translated in healthcare, pressures on healthcare expenditure, given its importance in state budgets, and led to member states adopting not only encouraging an increased involvement of private actors in the provision, management, and funding of care, what is classically understood by healthcare privatization, but also, and firstly, state disengagement from healthcare in the form of cuts in healthcare and expenditure and service levels, outsourcing of ancillary services such as catering and cleaning, or reducing publicly provided healthcare by the definition of minimum service baskets. complementary to that, member states also adopted several measures seeking to marketize healthcare, to make it more like a commodity to be traded on the market by adopting the so-called new public management measures such as purchaser-provider splits, contracts, case-based funding methods for hospital, the DRG, or again, performance indicators, benchmarking, targets, cost-benefit analysis. So we see all these three types of measures as actually healthcare contributing to healthcare privatization in a more encompassing sense. And while the adoption of these different measures has been uneven from country to country, they nevertheless all follow a common transnational script and lead to transnational linkages, as seen, for example, by the rise in multinational corporations in healthcare in the EU. Now, this healthcare privatization, understood in this more encompassing sense, has increased, we argue, the unevenness, inequalities in what we may see as a European healthcare space, in so much as it increased inequalities of access and labor force segmentation. And we try to make those inequalities and divisions visible in this figure. For example, those between private and public healthcare, inside public healthcare, between high-skilled and low-skilled positions, between healthcare and private care work, mostly in the informal sector in many countries, and between areas which avail of health services and the so-called medical deserts, most notably situated in rural areas which do not have access, do not have any health services. And finally, there are also divisions, regional divisions, and we figure here those which we illustrate in the article between Western and Eastern Europe. But of course, we acknowledge that there are other divisions, most notably North-South, that are also important. So if we look at European integration, we see that it fed into healthcare privatization, an increased unevenness of the European healthcare space. And we argue that this unevenness also fueled healthcare worker and patient intra-European mobility. And if we take that example of flows between Western and Eastern Europe, we see on the one side the movement west to east of patients, most notably what are called medical tourists, consumers, nationals of Western European countries, which respond to unaffordable, unavailable care by seeking faster, cheaper care in most notably the private healthcare sector in Eastern European countries. The same is the case for Central and Eastern European migrants in Western European countries who respond to barriers to access healthcare in their host countries by going back again, mostly in the private healthcare sector of their home countries. In the opposite direction, east to west, we have healthcare workers which respond to lower wages and poor employment conditions in their home countries by seeking employment in both private and public healthcare and care sectors in Western European countries. But in so doing, most of them are occupying lower skilled and lower waged positions. So what we see is that we have a movement, that is kind of feeding into each other. And we have on the one side, unevenness in the European healthcare, inequalities in the European healthcare space in terms of provision and access, feeding into this healthcare worker and patient mobility, and this in turn feeding into these inequalities, because we see that actually mobility plays on these divisions between public and private, between areas with healthcare services and those without. So if we try to see the links, we see that the cycle is buckled, and we have a perverse cycle between European integration, healthcare privatization, and healthcare worker and patient mobility, where these transnational processes feed into each other in a perverse way. Now, to conclude, we also have to take into account commodifying, the adoption of commodifying EU laws in the previous decade, and most notably the cross-border care directive in 2011, but also, and very importantly, the setup of the EU's new economic governance, which, as our research project showed, leads in healthcare to a common commodifying agenda, which mostly targets countries that lag behind in the commodification of healthcare in the previous EU governance cycle. So what we see, if we go back to our figure, is that the washing machine of this perverse spiral between healthcare privatization, European integration and governance, and healthcare worker and patient mobility is continued nowadays. So we leave you with an open question of whether the fact that we have these transnational linkages that are there and that are becoming important for health services on a local level, whether this doesn't warrant that trade union collective action has also to take place at the transnational European level. Thank you.
Roland, do you want to add something to that, or no, it was only Sabine actively presenting? So thank you very much, Sabine, for this presentation. I would like to use only 2 comments because it's actually a very excellent article, and we see very soon with Sabine and Roland at EPSU, Standing Committee for Health and Social Services. We were very active in terms of this directive on cross-border healthcare access, also with employers organization HOSPIM already when the directive was being discussed in 2011, because exactly we are very concerned about these issues that the patients will be going west, and whereas the Eastern European countries should pay for that. But there is also another issue that we need to be very concerned and careful with the EU health data space, when we know that the European Union is actually gaining more and more sort of role in terms of collecting and sharing information on the health data, which is actually used as an argument to improve research and tackle, pandemics and other diseases. But I think it's very important article again that we need to be, and we are with our affiliates in EPSU, very active, and we are observing this with a lot of concerns about getting more role of the EU in area of health and care, because we know that it can actually lead to more internal market competences. I would like to give now the floor to Caroline Murphy, who will be presenting the experiences of Irish trade unions in the long-term care sector. And I'm really, again, pleased to see Mary Butler from the SIP2 trade unions, who are very active in supporting long-term care workers in Ireland. So, Caroline, the floor is yours.
Thank you, Adam. I'm delighted to present here this morning on behalf of both myself and my co-author on this paper, Dr. Michelle O'Sullivan of the University of Limerick. So in the paper, our aim was really to look at tracing how unions in Ireland have attempted to protect and improve working conditions of care workers over the last 2 decades. So we reviewed 2 major union campaigns, and as the landscape changed significantly over the course of writing the paper, we also wanted to look at some of the key priorities that emerged for trade unions in Ireland during the course of the pandemic from March 2020 onwards. So in looking at some of the challenges in the sector, Ireland doesn't differ from many of our European counterparts in regards to those challenges. Population ageing and the availability of formal long-term care are a significant issue in Ireland. The over 65 population is expected to grow in Ireland by 20 to 25% over the next 2 decades. and the over 80s population is expected to more than treble in that same period. So we can see the trajectory for long-term care, and particularly home and domiciliary care, really increasing, while at the same time we see the availability of familial care and informal care decreasing. Coupled with that, as very much, I suppose, as Sabina has alluded to, we see significant restructuring, the introduction of a new public management and private management principles in how care and social care is structured. Between 2006 to 2019, we see the share of public funding very significantly declining in terms of publicly delivered care in favour of a massive increase in the amount of care delivered by the private sector, and also a decrease in the amount of care delivered by what was traditionally, I suppose, very prominent organisations in the delivery of care in Ireland with voluntary and religious backgrounds. So all of these things have really increased, looking at the marketisation of the sector and the increased regulatory issues that are emerging. In terms of Ireland, we do not have a statutory right to home care in this country. While there's a statutory right to residential or nursing home care, because there is no right to home care, we see very significant issues in terms of how the distribution is divided between the two. But more importantly, from an employment perspective, that lack of statutory regulation means that we do not have very clear regulations around who can provide home care and who those workers are and how they are protected within the labour market. In terms of the labour workforce characteristics, we see that it's a predominantly female workforce, almost a third are migrant, and they generally have low levels of flexibility, low levels of education, and are often involved in the sector for flexibility reasons. In terms of employment conditions, low formalisation of the employment sector, generally low pay. Whilst it is above minimum wage in most of the, even in the private sectors, it is still a long way off the living wage, which should be around €12.30 an hour in Ireland. It's a low hours and fragmented workforce, and often unsociable hours being worked by those individuals. So we looked at two campaigns. We looked at our long-running campaign around working hours security and pay restoration then in the non-profit sector. And what struck us, I suppose, most in looking at the campaigns ran by two of the main unions active in this sector, both ETUI and FORSA, were the fact that the unions had to have very different strategies when they were looking at publicly employed workers versus when they were looking at privately employed workers. So, for example, in the publicly employed cohorts, a lot of the campaigning and organising was based around the creation and subsequent delivery of collective agreements. Whilst in comparison, when we look at the very low levels of collective bargaining, of trade union membership that exist within the privately employed, it meant such a strategy would prove, almost futile in those areas. And instead, the emphasis really had to be on political lobbying and legislation in those areas. When we look at some of the campaign areas over the years, we can see the real trajectory, I suppose, in terms of time and dedication that the campaigns took. Looking back to the early 2000s, at that stage in Ireland, home carers were really seen as almost a self-employed group within the care system. They were not recognised to the same extent that their equivalents within a hospital or a residential care setting would have been recognised. So one of the first collective agreements that EPSU was very active, and FORSA as well, in trying to deliver was a collective agreement which recognised those individuals on the same salary pay scales and the same recognised terms and conditions as workers in more residential settings. As we moved through that decade, we started to see cuts in home help hours emerge. So we started to see things like, again, the lack of formalization and ad hoc arrangements in the system, meaning that people, if their client or their patient was hospitalized, they lost working time, they lost hours, and there was no remuneration for that. And then I think things, I suppose, really took a turn for the worst in the global financial crisis and subsequent austerity years, when we saw very significant cuts within the sector, and we really saw the emergence of 0 hours type working, or in this context, what we call if and when working, where we have that question mark over mutuality of obligation from the employer to actually supply a guaranteed number of working hours. We saw the arms of the state in terms of the Labour Court and the Workplace Relations Commission being very instrumental in having to intervene in order to ensure that collective bargaining agreements were actually put in place and were actually actioned upon by the state. And that continued with a very landmark case in 2013 and right up until 2018 when we saw further agreements. Second case we looked at was really around pay restoration. And in terms of pay restoration campaigns, that looked very much at the non-profit sector. So then the non-profit sector in Ireland, what we call Section 39 organisations are tasked by the Health Service Executive with delivering care in the community, and particularly to vulnerable groups like intellectual disability and mental health. And over the course of the austerity budgets, those organisations were very much instructed to, in line with the public service, reduce pay terms and conditions for workers. However, when we came out of austerity and when public sector workers had their terms and conditions restored, there was no subsequent automatic restoration for workers in those sectors. We saw unions campaigning very heavily, very much having to look to industrial action to try and instigate pay restoration campaigns in those sectors. There was an initial agreement reached in order to have pay restoration in about 50 of the largest of those organisations. But there were subsequently hundreds more where there was no genuine commitment from the state to restore pay until relatively recently, right up until 2021 is when we're now seeing action beginning to take place on those, very much as a result of significant campaigning that the unions did in 2020. And what I would say as well was that a very important point during COVID was that it was important that unions, were able to show that much of the campaigning and the issues that they were raising were issues that they had raised prior to the pandemic. These were not issues that emerged and came out during the pandemic itself. They were seeking restoration for agreements that they had reached prior to that. During the pandemic, of course, we started to see the invisibility of this work within the private home care sector and within the residential care sector have a light shone upon it. We saw very significant issues around the health and safety of staff. So a survey from April 2020 of home care assistants and healthcare assistant workers showed that about 70% of them had very limited training in COVID-19. There were significant issues around access to PPE, and we saw real questions raised over the adequacy of staffing levels, particularly in non-public health settings, eventually where the unions and the Department of Health and HSE reached an agreement around the deployment of workers from public settings to private settings. We also saw very significant issues around things like access to childcare services for those workers. This is a predominantly female workforce. So again, of course, those issues in tandem meant that supply of workers and workers' ability to fulfill their hours within the context of COVID-19 pandemic was constrained. In terms of lessons for the campaign, I think one of the major lessons we can see is that the campaigns need to be nuanced in the sense that they need to have different strategies which address the private sector, the non-profit sector, and the public sector. And we saw that very significantly in the Irish case. We see good examples of spillover effects as well, I think, across the different sectors. And we saw how strategies need to align, particularly for the private sector, with broader strategies that are going on in other areas. So, for example, unions were very active in campaigning for legislation that would address 0 hours and if and when contracts in the care sector. And it was very much on foot of, I think, working in collaboration with retail trade unions and trade unions in the hospitality sector as well, where those workers were also equally affected. In terms of future directions, one of, I think, the key things which has been highlighted through this is the non-profit workers, and looking for how we can try and align and change the terms and conditions for those workers in the non-profit sector in a more fruitful way. I think aligning between Section 39 workers where their terms and conditions are not aligned, whereas they are aligned for Section 38 workers, and these are workers who do similar roles but in a different classification of organisation. I think we also need to look at, much greater transparency around how the sector is financed, where profit is generated, and how funding is actually going into the sector. Increased transparency in the sector isn't just around profit motives and around improving conditions. It also has a very clear knock-on impact for the patient. So looking at transparency in the system in terms of how can we look at the role of the worker as an advocate for the older person or the vulnerable person. And insecure, unclear, ad hoc working conditions do not serve to allow individuals to serve that advocacy role, which is hugely important. And finally, I think one of the things we need to look at is the attractiveness of this sector long term. It's, you know, it's immune to offshoring in some ways. It's immune in many ways as well to some aspects of technology. And we need to look at how this sector can be better made more attractive as a career, so that it's not about starting terms and conditions, but really looking at a long-term career trajectory. So in terms of final conclusions, I suppose I would echo points that Sabina and Roland made around a coordinated European response. In Ireland, this is a political issue. It's particularly looking at older people and their voting habits. This is a political issue where politically many individuals won't want to intervene at this because it is seen as a political hot potato. And I think there's room then for things like a European directive in this area, which in many ways addresses some of those kinds of national political issues. And the second thing I would draw attention to here, which is I think the next battleground for home care, is technology. Technology is going to change the nature of care work. It is going to change how care work is monitored. It is going to change how it is delivered. And there can be opportunities for, I think, trade unions and workers in that, in terms of aligning that technology with professionalization and the skill mix. But there's also risks and there's also dangers in terms of how technology will impact care or will impact the time spent caring and the nature of, I think, what care workers recognize as really being their role as care workers. Thank you, everyone, and I look forward to some questions and engagement on the topic.
Caroline, again, thank you very much for this excellent presentation that you will receive to you. I just want to only make some comments that I forget about that regarding what you said about the solidarity. There is a need for trade union solidarity in response to those cross-border actions of the big companies and also in relation to health and care. We in EPSU, Jan, you will agree that we are working with our trade unions, not only on the EU level, but in across of the European region, from Russia to Kazakhstan. One of the ways in which we address this is being really active in the European Works Council. Already Jan Bilam mentioned this. And in regards, regarding to long-term care, EPSU, I think it was still this year or last year, was calling for the special investigatory committee in the European Parliament to ensure that we learn the lessons from the pandemic, because as you already said, and as we are saying with our affiliates, it's really exacerbating the existing problems on the social care, long-term care sector with privatization and the lack of investments. So I would like to now give the floor to our very good friend, Mary Butler from SIPTU. And also I would like to say that I think this is one of the last Mary Butler public presentations, because Mary Butler will soon retire from SIPTU. So we really miss you in EPSU as well, Mary, and also in terms of the SIPTU and our colleagues from Unizone involvement in supporting healthcare workers, in particular in relation to healthcare assistance that we are on the European level trying to organize and support, because I think healthcare assistance were also crucial in the times of pandemic. So Mari, the floor is yours.
Well, thank you very much for your kind words. And yes, I suppose I look forward to retiring in some respects. In other respects, I feel there's so much left to do, you know, but people are built on the work that we've done, and that's what we have to do, build on each other's shoulders as we move on. But in relation to I suppose the Irish story around what we used to call home helps, you know, like we began that journey with them, you know, a couple of decades ago, on the basis of bringing them into line with their public sector colleagues, because they were completely treated as precarious workers. They weren't even counted in the head count. They were just sort of there with no real structure around them. So the first thing that we really wanted to do was guarantee their contracts and their pay, because they were paid really, if the client was there, they got paid. If the client was in hospital or in respite, they didn't. So it was very precarious in that respect, that you were paid as based on whether the client was available to you. So we eventually, it took a decade, I think, really. We eventually got them agreed contracted hours, where they're guaranteed their contracted hours, irrespective of whether the client is in hospital or not. They're still paid. They can be asked to do other work, obviously, but they're still paid. Their wages don't fluctuate with the movement of the client, which was hugely important victory for us, because up to that, they were banking hours. They might have got paid, but they'd have owed those hours back. So that was a massive, they were always in debt with their hours, so they were never free, they never knew what they were going to earn. Or so we did eventually get that. And then our next campaign really was, they weren't paid for their travel time. If they were traveling from one client to another, that was on their own time. So that wasn't included in their contracted hours. It wasn't included for pay purposes. So they could have been doing 39 hours a week, but they could be traveling another 8 or 9 hours a week, which wasn't included. So the TICO judgment gave us an opportunity there to look at that. And we eventually, again, after a fairly strenuous campaign, got them to agree that their travel time was working time and should be included in their contracted hours. So now they get paid for their contracts include their care hours and their travel time hours, and they get paid for all their hours of work for the first time ever in 2021. I mean, it's shocking really to think that it's only now they're getting paid for all their hours of work, but they are now. We also secured a significant pay increase for them in the public sector. They went from our lowest pay band to the second highest pay band, on recognition that they now are not home helps. They don't do the washing, cooking and cleaning. They're doing intricate personal care. They carry out the activities of daily living. They clean, they change colostomy bags, they clean pegs, they do all sorts of things that healthcare assistants do in hospitals. These workers now do in a person's home. So that was all captured in the campaign to have their pay revalued in line with their healthcare assistant colleagues in the acute hospital. So now they're all paid the same. So we have a lot of work done there. We feel that the public sector worker is now as good as any healthcare worker in that respect. And what they have now achieved, we now need to achieve in the private sector, because the private sector is completely lagging behind that. And I was interested, to hear that, some of the private sector do pay more than the minimum wage, but you'll probably find that that includes then their mileage costs and their travel time, and that they're not paid separately for mileage if they have to use their own vehicle or whatever. We see the Ubers, we see the private sector going down the sort of the very precarious casual route of even being able to dial in care, phone in care. We know that workers in the private sector they're on an as required, and they're sort of back where our public sector workers were 20 years ago in many respects. And we have a lot of work to do there, but because we're dealing with individual employers, we can't get that collective grouping together. And there is no collective grouping in Ireland where they all come together, where trade unions are involved, where there's a stakeholder process. That doesn't exist for private sector care workers, at least not yet. So what we believe is the next campaign for SIP2, which would possibly help us with the private sector side, is the registration and regulation of home care workers. At the moment, they're not registered or regulated in any way. There are guidelines out there and standards that are desirable for education and training purposes, but that's as strong as it gets, desirable. We believe if they had a protected title, if they were registered or regulated in some way, that those workers would be able to come together as an organised group of workers under their protected title. And that would give them a bargaining or a collective voice that they don't currently have, because they're not regulated or registered in any way. They're just workers. They're just workers. Whereas if they were grouped under their protected title, we believe that would give them a stronger organising potential to actually command some of the things that we've commanded in the public sector, rather than getting embroiled with long, lengthy campaigns with individual employers or with political campaigns. That we should go directly to the worker and campaign for them to be registered and regulated and their title to be protected. Because at the moment in Ireland, and I think in England is probably, I think only actually in Ireland and England, they are the only group of workers that can call that. No, you don't have to have. You can be, anyone can call themselves a home care worker. Anyone can call themselves a healthcare assistant. So you can't just call yourself a nurse or a doctor, but you can, in the Irish context, call yourself a healthcare assistant or a home care worker. So we are now moving into that stage of our campaign now, where we want to organise workers around their protected title. So the first journey really is to get the title protected, and that's where our energies will be going, in the collective sense for private sector workers as well.
Yeah, sorry. Thank you very much. Thank you very much, Mari. I think it's important what you mentioned. I was taking some notes. I think there's issues about travel time not being paid. I think it was going for years, and it's not only in Ireland. As far as I remember, Unizone, again, our affiliate, was very active in these issues in the care home, and I think they won one of the case in the UK in terms of, paying a proper compensation for the travel, because this was against the national minimum wage. I think this is one of the reasons why the companies are making a lot of profit. Also, in terms of collective bargaining, I think this is crucial. No, this is crucial. This is what we are here as a trade unions, for collective bargaining, and if possible on the European level, a European social dialogue. As Jan Willem said already, we issue with the social employers the request to establish the European social dialogue in the social care sector, because we have 12 million workers in the social care which deserve a social dialogue. And with SIPTU and our colleagues from Unizone, we are very active in terms of supporting another important part of the healthcare sector, which are healthcare assistants, which are again important for us. And the digitalization, again, I was actually mentioning, like behind here to Philip, that it's against another issues, in particular for social care, when we observe some companies which are, try to make a profit from providing care on a Uber basis. Without further ado, we have like 15 minutes for questions and answers, and I already have here some questions from our participants. So I think you also could see them, and Jan Willem is with us as well. One is from Peter Prose. It's about the policy questions. Can privatization of provisions with the profit center priority actually deliver care service quality? UK's corporations have used complex taxation techniques, we know about them, who challenge collective bargaining and reduce public sector conditions to basic minimum level. Is this phenomenon similar across the EU partners? So I think it's just, Jan Willem, do you want to answer, or shall I?
I can. I can. In the chat channel, we published a number of research reports which are done by SICTAR, which is a independent research group, linked also with ETUI, a research group from Australia, which the unions and others are funding, and it does research into those complex tax structures. And we published a report they recently did on how the Greek Orthodox Church is escaping taxation on elderly care homes in Greece. And my colleague from the PSI, Public Service International, referred to another report. So we see also in a number of multinational companies, I already mentioned Orpea, but there are others, in which tax structures are used to pay low amounts of taxation. As of course not so different as in other sectors, and some of you know we have been involved also in the discussion around the taxation of McDonald's, for example, that in light of the Fight for 15 campaign, McDonald's, which also escaped paying a lot of its taxes through complex tax structures. And in the care industry, especially in residential care, elderly care homes, because of the real estate side of their business, the risk of setting up those structures and escaping paying taxes is an important issue. So I also saw in the chat channel a question of someone of the Eurofound in terms of the forthcoming European care strategy, and if there are conclusions to take forward. Obviously, we have to discuss that with our unions. But if the European care strategy doesn't recognize what all of these reports, and Adam referred to it, address, lack of staff, lack of attention for paying conditions, poor working conditions, they are mentioned in all these reports and including in conclusions of the Council. If the European care strategy doesn't recognize these issues, doesn't come up with at least a discussion with the trade unions on how these issues can be addressed, like Mary said, through collective bargaining and other measures. I mean, the European care strategy isn't worth the paper it's written on, at least not for our members, not for workers in the sector. So that is certainly something we would expect from that European care strategy. Linking back to the first presentation, the other thing which needs to be clear, which is EPSU ETUC policy, is that we cannot go back to these to a period of austerity measures in what seems to be announced in 2023 with further cuts in public funding for these sectors. We really cannot go there. So we want to see in that European care strategy also commitments to funding through the European semester or other mechanisms, which is already addressing some of this. So that is what we expect of that European care strategy. I think it was Hans of Eurofound who raised that question.
Roland, you wanted to say something? Sorry, because you raised your hand.
Yes. So what I would like to do is answer to some of the questions that have been put forward in the chat. And the question of Peter has already been answered to some extent. And he asked the question, as you have heard, whether private delivery would lead to better quality. And to that, I would just simply answer, that is not the motivation why private enterprises enter into the sector. They enter in the sector to make to grow their businesses and find new investment opportunities for private gain. Second question that Heike put forward was related to minimum wages in Germany, which have now been also declared important or applying to migrant workers from Central and Eastern Europe. And she's concerned that kind of the imposition of minimum wages would lead to Central and Eastern European workers losing their jobs. Here, I say no. The evidence that we get from countries like Switzerland, which have a much stronger enforcement regime of minimum pay, doesn't lead to the fact that Eastern Europeans will lose their job. So in Switzerland, we have a high proportion of migrant workers in construction or healthcare. And although the minimum wages are much better enforced through stronger measures than in Germany. And the reason why that is the case are very clear, because workers from Central and Eastern Europe are not just getting the jobs because they are paid lower wages. So they are as good as Western workers. And if we pay equal pay for everybody, then it doesn't mean that Central and Eastern European workers would lose their job because they provide as good a service as everybody else. But then let's maybe move back to the more bigger questions. And Jan Wilhelm just made a very important point, and that's the point that we wanted to make with our presentation as well. And also in response to Mary, we have to decide where we fight, at what level we fight. So far, many social policy scholars have looked at healthcare as if this is a national issue and just look at different varieties of national systems and then focusing on national employers. And that leads to a very difficult fights, as Mary said, you know, employer by employer on the local level. But what I think, if we analyze the problem and take a step back, we see that here are processes at work that are governed by European laws and European policy interventions. And the first fight that is very crucial for healthcare and all public services is the fight about the Stability and Growth Pact. So that is a key issue now in German negotiations about the new government. Will the suspension of the Stability and Growth Pact, which has been decided when even the Commission and the Council realized that the austerity kills people in the COVID pandemic, but the Stability and Growth Pact is only suspended, so there is now a big political debate. What will replace it? Will we go back to austerity, yes or no? And that fight can only be won at the European level. So we have to kind of work at that level, in my view. And the second point is also, Caroline made also the point in her conclusion, the issue of long-term care. This is also really an issue that is involving migration, involving European health. And that is also a strategy, I think, where a campaign of EPSU in particular at the European level would help, and also maybe a European framework directive. And to those, maybe in Scandinavia, I've seen similar discussions in relation to wages that say we shouldn't have any directive in relation to health at European level, because health would be a national or local competence and not a European one. I would respond, we have to look at European policies, how they work de facto, not how it appears if we read legal textbooks. Because it's true, if you have a very narrow-minded approach, the European Union only has the competence in public health for health level kind of interventions. But as we have shown in our paper, we have seen that the single market project and also the monetary union, and in particular the new economic governance interventions based on the Stability and Growth Pact and based on the new macroeconomic imbalance procedures have allowed European executives, the Commission and the Council to make very concrete interventions in countries. Even Italy was praised in 2019 for cutting public hospital beds in 2019. Just before the COVID crisis. So we have to change policies at the European level in order to win our cases in this regard. Or that is at least my opinion as a fellow researcher in the area.
Thank you very much, Roland, for this explanation. Also to another questions. One of the questions coming here from our colleagues from Age Platform is that I miss the realities of those receiving care. What are the challenges they face? What should be the goals and ambitions of care workers and services? This is where organizations like mine, of older people, can play a key role by partnering with unions. I think we cooperate very closely with Age Platform as well, also on the WHO level. And we do have responses to address those key questions. So I think it's also important maybe for scholars to do some more research in terms of the role of the care recipients and the role of the NGOs in that respect. Is anyone wants to maybe comment on that? Because there was also a comment on about Heike saying about exactly on home care workers or living care workers. Roland was already answering these questions. I work in Switzerland when I was responsible for organizing living care workers, and indeed in Switzerland, because they are not part of the EU, the enforcement of the minimum wage is much better, and we have a collective bargaining for the living care workers. So, is anyone wants to answer about the care recipients? I think the care recipients are crucial in this sort of situation, because those are who receive care and those who actually paid a lot in terms of the lowering the quality of care as a result of austerities, as a result of privatization, commercialization, so on and so forth. So I think it's important for us to also focus on care. So if any one of you wants to answer these questions to Age Platform, colleagues, any volunteer?
Sure, Adam, I'll address that one. I think, it's a very nuanced area in terms of how we address the patient side of this, and also more than just the patient, but the patient's family. In Ireland, for example, an individual client can have a very significant mix of care from care that they're delivering or being received from a publicly employed care worker, care that they're then supplementing from their own pocket in terms of private delivery. And I think as we see things like technology increase, we'll even see, for example, you know, as Mary referred to, the rise of things like platform work in relation to the delivery of that care. And of course, for both the worker and the client or the patient, the issue then is, how do we ensure that the care quality is the same across each of those parties and that each of those parties is equally protected? So, for example, when we look at things like the record keeping, there may be differences not just in the care delivery and the care time, but in the administrative elements of how care is delivered between a private sector agency and a public care worker. So we need to look at that. There was another question, I think, which ties into this, and it was looking at the role of cities, which I don't have a very specific answer on in terms of maybe an economic geography aspect, but I would link that question that was raised with this issue of patient quality care delivery as well. And one of the things I would say is that the care and the patient in this is often treated very homogenously. But we're really looking at very different heterogeneous issues here. So we can be looking at the older person, we can be looking at somebody with physical issues, somebody with mental health or intellectual disability issues. And one of the things which I think is not being given sufficient attention nationally or at a European level is the extent to which we can link the skills of the home care workers very directly with the needs of the client. So for example, particularly in urban areas, we should have enough of a care demand volume that we should be able to supply care among home carers and home care assistants that is tailored to that need. So for example, individuals who can gain a qualification in delivery of care which is specific to somebody with an intellectual disability need or a mental health care need or physical need or Alzheimer's or dementia or so on. And that I think is something that we're not seeing. We're seeing that in the nursing sector, we see that in multidisciplinary care teams, but when it comes down to the level of the healthcare assistant, the conversation seems to end there. It doesn't seem to go to that extent of a tie-in between how these individuals, which often are the ones spending actually the most amount of time in the home of that individual, can really be linked into that care plan. And I think the inclusion of these individuals within the care plans and care plans which reflect that skills and training will be hugely important.
Yes, I totally agree with this. I was also want to add this in terms of digitalization. It's not only an issue for the social care workers or long-term care workers, but also for the health workers. So as I was saying again, that EPSU was responding to the EU consultation on the EU health data space. And we have the same concerns as nurses, but also as a doctors association in terms of, you know, who is collecting the data of that, who is researching the data, who has access to those data, and so on and so forth. So I think it's again, it shows how important the social care and health are interconnected in terms of ensuring that we will face the same problems of digitalization and also artificial intelligence in those two sectors. So this is what EPSU approach is. There is also one of the questions exactly that cities, and I would like to maybe Jan Willem to answer this, because cities is again local governments and public services. So I think it's very much the cities the cities we work have been focusing a lot on increasing the attractiveness of care jobs. What role do the speakers see for cities to help tackle some of the challenges presented today? Cities is the local government, cities is public services, isn't it? So I think a lot of local governments already have some care homes, but they were not have enough money to run them, and therefore that leads to privatization. So I think it's important again to highlight the role of the local governments in delivering and supervising long-term care, right? So.
Yes, thank you, Adam, and thanks to the person who asked the question. In a way, it goes back to what was addressed also in the answer of Roland, that the state or local authorities do have a responsibility for organizing care. Maybe the way in which it's organized can be different, but they do have a responsibility of which they cannot walk away. Think of the terrible situation in Italy or Spain during the first days of the pandemic. I mean, who is held responsible. It's often not a private care owner, but it's the local authority, or it's the state or the regional authority in some cases who is held responsible. So that's I think the first point. Second, of course, is that especially in in the area of local authorities in big cities, you can organize care work in different ways. I mean, the previous speaker just mentioned how one such way could work, also improving qualifications, but also stability of working conditions for workers in home and in social care. So that is an area of attention which we also try to raise. Adam referred to it in our discussions in the European Parliament to try to get that investigative committee going to look at the lessons we can learn from the pandemic and how care work should be addressed. In the end, responsibility and funding are key questions there, of course.
Thank you. And there is also two questions to Mary Butler. One is from Karin Pepper, again, our friends from the Domestic Workers Association. It's about the Migrant Rights Centre in Ireland. That's, how you could empower migrant care workers in terms of care co-op, and also about the protective status for the domestic workers. So if you could answer this, Mary, like within 2 minutes, because we need to close the session, because people need to come back to work, because the lunch break is finally.
Well, look, I suppose in relation to the protected title, I mean, we believe that those workers who work with vulnerable people in the community should be registered. And that the days of people being able to work with vulnerable people who are not registered or regulated in some way is over. And we do think we also think that if we had a protected title for those workers, all of the other things would permeate from there, the qualifications, the education and the standards and so on. But that would be, we think, one way of organising care workers around their protected title. The Migrant Rights Centre are doing a type of a co-op. It's difficult to get full information about it, but again, the workers within that co-op provide care to people in their area. And it's sort of an informal structure. And because we don't have any national standards, we presume that they're following the guidelines that are given by public health. So again, we don't know what they're paid. We don't know how they're paid. We don't know whether their travel time is included. We don't know. We think that, yes, it will be a way of bringing those workers into a collective group. And over time, we might be able to start working with them in relation to their pay and conditions and things like that. I suppose our focus, and this is why I'll finish here, our focus is really on the pay and conditions and the qualifications of health workers. Because for the most part, most health workers that we come across, whether they're in public or private health, do the best they can for the people they look after. And they provide the best care that they can. And that their pay and conditions rarely, a person who gets low pay doesn't provide less personal care. A person with low pay provides the same caring attitude, but the tools to do the job mightn't be the same. They mightn't have the same activities to offer a client and things like that. So the Migrant Rights Centre is a way of doing it, but it doesn't address the issue of the pay and conditions of workers in that sector.
Thank you very much, Mike, for this explanation. So because we need to really close down and actually allow you to have some break still during the lunchtime, because it will be over soon, I would like to make one comment at the end. Remember this, on the 29th of October, there is the Global Day of Care Workers. So there will be some activities prepared by the International Trade Unions Federations. We will keep you informed. I already spoke too much. I think, Jan Willem, do you want to say something at the end?
No, just to thank everybody for being here, and as Mary and others have mentioned, to keep up our fight for better pay and conditions for the workers in care and healthcare services. But thank you for being here. A great pleasure.
And I would like to give the floor to our hosts today for officially closing this successful webinar. And also, there is some things for us in the future transfer issue. One is about the domestic care workers. Another is about digitalization, Philip. So it's probably for you something to think about with our academics here.
Yeah, absolutely. Thank you to EPSU, to Jan Willem and Adam once again for the idea and all the participants. There was an interest for having the transfer issue on health. There is in the chat, for those not having noticed, we said that if you send us an email, we will send you a free copy of transfer. We will give also few copies to EPSU when you return, and to say hello to them. They will give you a gift. And I think that's really what transfer is. It's an academic journal, is published by Serious, but for the trade unions and for the public debate. And that's what we organize. And I will return to something that Valeria said at the beginning when we discuss about the issue. We said clearly we don't want to have just a bleak picture about what is happening, depressing, etc. Because there is a lot happening in this sector, and there is some victory, there is some positive sign, and we have to balance, not to be over optimistic, but just not to give only a very pessimistic view. And I think it was the article in this special issue of transfer succeed to do. So have a nice lunch, and I hope to see you to a next webinar. In the next issue of transfer, there will be one on the COVID crisis in the first issue of next year, and one also on the green transition. It's the next issue. And so if you're interested, go on the website and see the article that will be published in transfer. Thank you.
Thank you very much, guys. That I can see it here. Thank you, bravo, bravo. Thank you for Sabine, Roland, Marie, Caroline, Matthew, and our colleagues.
Okay.
Yeah. Thank you. Thank you.
Bye.
Bye.